topics, all the important salient features by which we are going to go. It's beneficial for all the students who are related to the medical in any way of the other. For example, not just the university, but also for the students who are giving the PG exams as well. Okay. It is spelling is slightly right. It is only ANKIT. Okay. So yeah, the today's session is based on the stomach and the you can say the gut part over here. In the main long questions, we are basically going to deal with the stomach part, then the duodenum part, and also about the positions of the appendix. While talking of the short questions, which normally come in the range of 2 marks, 3 marks, or max to max 3 or 4 marks to the max, they are ligaments of treats, short notes on jejunum and ileum, and mainly their differences. Also about the Medicos diverticulum, as it is clinically important, and ileocecal valve over here, right? So they also discuss the ileocecal valve. Okay, here are the core features of Auricle. I am sure you guys are aware with it. So all these recorded live classes plus lectures you have over here, plus the notes also. And also don't forget to pay attention to this slide. It's a limited period offer. It's valid only till July of 15th. So, and the 3-4 days more. It's a combo plan and it is regulated in 13,499 rupees, right? You have over here in this plan, you will have all the features of the app. Plus also you also get a hard copy books over here as well with simplified, these images with simplified fun zone and exam modules, practical sessions and all. So don't forget this. You have 4 days. Think about it. It's very good for the preparation. So combo plan rupees 13,499, right? Where you get all the features of app, plus also you get hard copy books as well, right? So remember this part and do share to your friends as well. Okay, now let's have a look at the today's session. Okay. Let's move on to today's session over here and yeah. So we'll deal with the stomach over here. Just a long question. So describe the relations. The questions will come in this manner only, that describe the relations, blood supply, lymphatic drainage, and applied anatomy of the stomach. So as a long question, let me write over here as a long question, right? As a long question, the stomach normally comes. Okay. So be prepared for it. So how to start with? First of all, this external features. Then see, it's a basic topic that in abdomen beginning I told you that to understand the abdominal wall and the peritoneum, that's a tricky part. That's the conceptual part, right? Now, as you delve more into inside of the viscera and the parts of the abdomen, there the main features will be the gross anatomy of the organ, the relations, blood supply, nerve supply, lymphatics, applied anatomy, all that, right? So these small subtopics are common to all the viscera. Okay, so let's start with the stomach. The stomach in the beginning, if I may ask you guys that we dealt about the intra or the retroperitoneal. Stomach will be intra or retroperitoneal organ. It is basically our intraperitoneal. It is basically our intraperitoneal organ, right? So remember that. Okay, so you can easily make out this diagram. It's very simple. Where you should always know how to draw the esophagus in the lesser curvature, in the greater curvature, and continues as the first part of the duodenum over here, right? This is how you can easily make the stomach. And then, as we know that it is a continuation of esophagus over here, and the upper part is known as the cardia, right? It is known as a cardia over here. Let me highlight it as a cardia. Fundus is the part which is above the level of the gastroesophageal junction. Now, this is where the basically when you take an X-ray, a normal X-ray, the gastric air shadow, right? Air bubble is seen over here, right? Whatever you ingest, whatever you swallow, whenever you swallow along with the food and the water, the air is also swallowed in. And air being lighter than the food particle, obviously, is going to accumulate at the upper level of the stomach in the fundus region. And this whole major part of the stomach, that is the body. The bulk of the stomach is the body. Then you have over here the pyloric antrum and the pyloric canal over here. This whole region is the pylorus. Now here you will have the sphincter. It is known as the pyloric sphincter over here. So it is quite, we can say, quite thick over here. If you hold the stomach in your hand, in the dissection hall, on the viscera classes, when you hold the stomach in your hand, that end of the stomach, which is very very hard, very thick, that is the pyloric end of the stomach. You remember that, right? Because esophageal and this end over here, the gastroesophageal junction, it is more of a physiological sphincter than an anatomical sphincter. So it is not as thick as your end of the pyloric end. And then you can see it continues down as a duodenum. This obviously the greater curvature, that is the lesser curvature. Okay, so basic diagram, you should know how to make it. Then some relations over here. You should know this. See, point over here also I need to mention is whatever you are reading, if you have no interest, then things will become very cumbersome, very bored, and very difficult for you guys. So, the moment you are reading anything, I'm talking right now for the anatomy part, this topic over here, you should know what is the importance of this particular topic, not just to pass the exam. That is okay, one small thing. But mainly tomorrow when you're going to get a degree, you're going to do some operations or anything like that, you should know what exactly is there and how it is going to practically help you later. For example, over here, you should know that the lesser momentum, which we have dealt earlier in our previous classes, is going from lesser curvature of the stomach to the liver, right? If you can recall that, let me make it like this over here. This was the lesser momentum over here, right? If you remember, this was the lesser momentum, which was going from lesser curvature to the liver over here, and the liver, it had this right inverted J-shape attachment into the liver also, right? We will study more when you study the liver part. This was our lesser momentum. So lesser momentum is this. Greater momentum goes from greater curvature of the stomach to the transverse colon. We discussed previous session that this is the attachment of the greater momentum. It goes down, covers the entire intestine. It rolls back, then it goes to the transverse colon, then continues as transverse mesocolon. Okay, gastrosplenic ligament. Now, gastrosplenic ligament, the name itself is sufficient. It is going from stomach to spleen. Spleen is to the left of the stomach, so it goes from greater curvature. Gastrophrenic, phrenic, I told you previously also, phrenic refers to the diaphragm. Whenever you hear the word phrenic, it refers to diaphragm, right? Diaphragm. So this ligament will obviously go to the diaphragm. So you remember that, okay? Okay, then visceral relations. This is very important again. Why? Questions will come not just in your first year, but later on, questions will come. And you should know, even if you are a surgeon or not later on in your life, what are the relations of any particular organ. Not exactly, but you should have a good idea that what surrounds the structure. Because suppose there is a malignancy to any structure, what else structures it can involve. Okay. Or if you are becoming a surgeon, the moment you enter into that organ, or how you are going to reach that organ, and suppose you are going to lift that organ, you should know what lies behind that organ. Or suppose you are searching for the organ, you should know what structures are covering that organ, right? So have this basic idea. So visceral relations, let us see relations on the anterior surface. So this will tell you that what are the structures which are covering the stomach on the front. So you have the liver, as I told before also, that liver is a huge organ, it will cover, and you will have the diaphragm. Diaphragm is not a horizontal tube, it's a J shape. So diaphragm and the liver are going to cover the stomach. Remember that. Now, relation of the posterior surface. This was the anterior. Now, this we are looking at a posterior surface relations. The moment you lift the stomach, what are you expecting? What lies behind the stomach? You will have the left kidney and the left adrenal. Why left? Because the stomach lies to the left of midline. Okay, so you'll have left kidney. Then you will have pancreas. You will have transverse mesocolon. You will have left colic flexure. You will have spleen. So you can understand how important structures are all of this. And do remember that in the stomach, applied part, let me tell you, you have a lot of gastric ulcers, which you hear a lot of time. And if the patient doesn't take treatment, or if he continues to insult his or her body, then the gastric ulcers might later on even perforate. And if there's a posterior gastric ulcer which perforates, then the fluid may will go to lesser sac, and then they can involve these organs. So you should know that behind the stomach we have the spleen, pancreas, left kidney. All these structures are lying behind the stomach. And remember that just behind the stomach, we have the lesser sac. The cavity on the posterior, just to the posterior of the stomach, is the lesser sac. Don't forget this. This we have dealt in detail previously, right? You remember, this we have dealt in detail previously. Okay, so remember this. Relations are important. And let me tell you, tomorrow when we will give the exams, be it your NEET PG or INI or next, whatever exams you are giving, there will be some exams, obviously, because the seat ratio is different. So questions will come from there. Now coming to the blood supply. Now blood supply, we will discuss the arteries also later on, but do remember that the stomach lies in which gut? Fore, mid or hind gut? The stomach lies in the foregut. Okay. So therefore, it will be supplied by which artery? It will be supplied by a celiac trunk. Celiac trunk that is coming from directly from the abdominal aorta. From the abdominal aorta. Okay. So stomach is supplied by ciliac that is coming from abdominal aorta. This basic thing you should know for sure. Here, what is written over here as CT. Let me encircle it. This is written as CT. This is the celiac trunk. So this artery is coming up from abdominal aorta. From abdominal aorta. Now it gives three major branches. How many major? Three major branches, and that you can remember with the help of a mnemonic also over here. Though I don't prefer giving mnemonics, but sometimes it might help you just on a lighter side. Remember mnemonic left hand side. Left is L is your left gastric artery, H is the hepatic artery, and S is the splenic artery. Out of these, remember, splenic artery is the largest branch of the celiac trunk. Okay, so let me underline over here the left gastric artery. Okay, this is L. Then hepatic artery is over here. Okay, and this tortuous artery will be the splenic artery. So these are the three major branches coming from the celiac trunk. Coming from where? Coming from the celiac trunk. Okay, left gastric, hepatic, and splenic artery. Okay. Now see what happens is they are going to then give a lot of branches. Now let us use the highlight over here. You can see this left gastric artery. It is going towards which momentum, lesser or greater? At the lesser curvature, there will be lesser momentum. So it lies in the lesser momentum and gives off the branches which are supplying the lesser curvature. Plus you can see the branches also going towards the lower end of esophagus. Okay, this is the left gastric. Then look at the hepatic artery over here. Look at the hepatic artery. Let me use a say different green color over here. Look at this is the hepatic artery. Okay, the hepatic artery over here. This hepatic artery over here will give off one of this branch, that is the right gastric artery. So this which I'm highlighting now is the right gastric artery. Again, it is going in the lesser curvature. So this right gastric and the left gastric will be where? In which structure? Lesser momentum. So they are not moving in space. They are inside the double layered fold of peritoneum known as lesser momentum. This is right gastric. Then you also see the hepatic artery. The hepatic artery over here will give off a branch that is going behind the duodenum. This branch that is known as your gastroduodenal artery. Which artery? Gastroduodenal. And this will give off this artery that is going towards the greater curvature. This is known as the right gastroepiploic artery. Okay, this is known as right gastroepiploic artery. After giving off, so this hepatic artery, after giving off the right gastric artery over here, after giving off the gastroduodenal artery over here, then it continues as the proper hepatic artery. But this we will learn in case of liver. This goes into the liver. And this hepatic artery is one of the portal triad. So it runs in the free right margin of lesser momentum. Got the point? So just to revise, celiac trunk gave up left gastric, celiac trunk gave up hepatic gave up the right gastric, then the gastroduodenal. You can see the dots, they are going behind the duodenum. This is a very important relation when we'll deal with the duodenum. And then gives up the right gastric. Now comes the splenic artery. Now some of you might be wondering that, sir, why you are telling out the splenic artery? It is related to spleen. Yes, but it also supplies the stomach. Let us see how. Again, this dots in the splenic artery, and it is a tortuous vessel. Dots meaning by it lies behind the stomach. This artery is forming where it is going behind the stomach. Now this splenic artery, as it reaches onto the hilum of the spleen, it will give off two major branches, left gastroepiploic and the short gastric artery. Wherever in the terminology you hear the word gastric, G-A-S-T-R, gastric, it is related to the stomach. Gastric, gastro, right gastric, left gastric. Are you getting my point? So wherever the word gastro comes, related to the stomach. So splenic artery, before it enters the spleen, it will definitely supply the spleen. But before it enters the spleen, the splenic artery will give up left gastroepiploic that will run where? In the greater omentum. And short gastric artery will supply which area? Will supply the fundus and the fundus area mainly and the greater curvature area. So this will be supplying this area. Okay. This is the short gastric artery, the cardiac fundus area, and the left gastroepiploic will be over here. This is how you can understand the entire blood supply of the stomach. Now, why is that important? Malignancies of stomach spread via blood. Okay. Or any ulcer perforation over here, you're operating and suppose there's a bleeding, you should know now the artery. Suppose you are operating on, say for example, on the greater curvature of stomach, and suppose the bleeding starts. You should know that okay, the branches over here in this region are coming from a splenic artery. So if you can get hold of splenic artery, just ligate it for a moment, and then you can just repair. You can just wash off the blood and look at the bleeder. This knowledge is going to help you a lot in cases of in real tough times. Okay, now This was the arterial supply. Now, whatever you study, they are giving in the written form over here. There's a lesser curvature. Lesser curvature will have these branches. Which branches? Left gastric. Okay, let me just highlight over here. Lesser curvature will have left gastric and right gastric. The greater curvature over here will have what? Right gastroepiploic and left gastric. The fundus will have short gastric arteries. We have seen which are the branches of which arteries, whether that is written over here. Now, this is about the venous drainage. Okay, so let me just correct over here. Now we are looking at a venous drainage. Okay, so there are arteries, so obviously there are going to be veins as well. The point over here which we need to understand is, just a second. Yeah. The point over here which we need to understand is that when we learn about the gut part, then obviously that there's the artery is going to carry the blood towards the gut. Okay, and the veins from here are going to carry the blood away from the gut. These arteries we all know are coming from the aorta, and the veins we all know are going where? To the IVC. No, they don't directly go to IVC, but where do they go? They first go to the liver. And from liver, you have another group of veins which are known as what? Which are known as hepatic veins. Those are the veins that goes to IVC. So when we are reading of any venous drainage in the gut, it will not go to the IVC directly, it will go to the liver. And how does it reaches liver? I'm sure most of you know that there is a portal circulation over here. There's a portal vein over here. Vein. So all these veins which are coming from the gut, all these veins which are coming from the gut, let me make them say blue color. All these veins coming from the gut will be draining directly or indirectly into portal. This is how whatever we eat, first is metabolized or first it passes through the hepatocytes of the liver. Okay, this is clear. Then we can see over here the major veins. You have right and left gastric veins. You have right and left gastric veins. They drain directly into portal vein. Then you have right gastroepiploic vein and you have left gastroepiploic vein. The right gastroepiploic vein, it can be a very good question. Let me tell you, it has been asked also, but very less. That the right gastroepiploic will drain where? It drains into superior mesenteric vein. Some of you must have raised eyebrows by now. That's a superior mesenteric vein. How is it possible? Because superior mesenteric artery, you have told us, and we know also that it is supplying the midgut. So therefore, the superior mesenteric vein should be draining midgut. Yes, you're right. Then how this vein over here, which is a vein of the foregut, is draining into superior mesenteric vein? They don't go into complexity so much. Don't think of the medicine as black and white. It is very gray. In medicine or in anatomy per se, when we study anything, we have to apply some practicality over it. Now, the thing over here is even the superior mesenteric vein ultimately has to go where? It has to go to portal vein only, which has to go to liver. So this right gastroepiploic vein, anatomically, whichever vein it sees nearby, it will drain into that vein. So therefore it drains to superior mesenteric, and I'll show you the image as well. Second thing is there is no vein known as celiac vein. Like you have the celiac trunk, celiac artery. We don't have anything which is known as the celiac vein. So in that case, okay. Now coming to the last one, the left gastroepiploic and the short gastric vein, they terminate in the splenic. But splenic vein will form the portal vein. So ultimately, what will happen? You'll understand later on that it is this splenic vein. Let me write over here, and the superior mesenteric vein. So we have the splenic vein and we have the superior mesenteric vein. These both combine to form the portal vein. This should be clear to us. Okay, those are the veins. Lymphatics, so again, when you will understand about the anatomy of the stomach, why is this lymphatic part crucial? Again, because of metastasis. Gastric carcinomas are not that uncommon. Plus, the more you eat, the more the public eats more of masala food and this pepper, high pepper and chili foods, more acidity, more chances of gastric carcinoma. Plus, you have dysplasia and metaplasia is also there. Plus, it's also genetic. Countries like Japan, they have very high incidence of having gastric cancers. Therefore, why I'm telling you over here, because due to this only, the lymphatics have gained importance because the cancer will spread via lymphatics only. So along lesser curvature, there are a few lymph nodes which you should know. You have left gastric lymph nodes, Along greater curvature, you have right gastrofloic, you have pancreatosplenic lymph nodes, you have the right gastric and the hepatic nodes also. So ultimately, they all will drain where? They all ultimately reach as a celiac group of lymph nodes. They all reach where? To the celiac group of lymph nodes. Okay. So while doing a surgery, you should not only take out the organ, you should also know that even if you've taken out the cancerous part, you should have also tested about the lymphatics, lymph nodes, which has been involved. Because if you don't remove the lymph nodes in during the operation, you close the body, the cancer will keep on spreading. There is no point in doing the operation like that. Applied anatomy of the stomach can be asked. We all know as there's a couple of things. I already told you gastritis and gastric carcinoma. Let me tell you, because we see patients also. If a patient is coming to your OPD, okay, with a pain in the epigastric region, epigastric, I hope you all know, above one like us, below the xiphoid, the region of the sternum, more than 90% of the times it is a case of gastritis. So it could be acute or chronic gastritis. The gastric pain is felt in the epigastrium because it is very common in India. Gastric pain is felt in the epigastrium because stomach is supplied from. The reason is this, because stomach being a part of the foregut, now sympathetics, they carry the pain and it is a T6 to T9 and it is that region, okay, T6 to T9, where you will feel the pain. It is in the epigastric region. Second is gastric carcinoma. So that also we have discussed it quite a number of times now. The gastric carcinoma can metastasis can go through. This basically means lymph nodes. It's a lymphatic duct. Okay, so it can spread over here. On stomach, also remember that there can be a question on histology as well. Histology is dealt later on, but understand. Stomach main function is your digestion. Okay, bit of absorption. You'll see some glands over here. You also see the layers like mucosa, submucosa, muscle, and the serosa over here. So we'll discuss them in detail in the histology part. Histology, a few differences are shown in this table, like cardiac, body, and pylorus. Some cells are written over here, but let me tell you, this is dealt better in detail in histology part. You don't worry over it right now. Okay, let us move from stomach now. Let us come to some basic idea of the small and large intestine. Because this much stomach you should be knowing at least. Practice also diagrams. So with starting the gross anatomy, the relations are important. Blood supply is important. Along with blood supply, and lymphatics is important. Applied anatomy, they are important. So now let us talk about the small large intestine. The small intestine extends from pylorus to the ileocecal junction. We all know the main three contents of the small intestine is your duodenum, your jejunum, and your ileum. Okay, DJI, duodenum, jejunum, ileum. The small intestine basic function is digestion and absorption. Therefore, you will see a lot of surface area in the small intestine. Because more surface area, more will the food be digested and absorbed. Simple as that. So always remember in a small intestine, the surface area will be huge. Okay. And a small intestine, if you look at the abdominal outlook of any person, the central region of the abdomen is the small intestine over here. And the small intestine, the upper left part is jejunum, the lower right part is roughly ileum. But what about duodenum? Duodenum, remember, is retroperitoneal. So it is behind. Jejunum and ileum are intraperitoneal. They are the ones which are moving. And when you put your stethoscope on the abdominal wall and wait for a few seconds, the peristaltic sound which you hear in your ears, so the stethoscope is the one which is basically occurring in jejunum and ileum. Okay. And so small intestine is what part? Is this central part over here? Is this central part over here? That is a small intestine. The periphery part over here, if I put the yellow color, this periphery part over here, this is the large intestine or the basically the colon part. Okay, remember that. Now, large intestine extends from the ileocecal junction to the anus. Fine, I guess we are aware of it. The structure of large intestine is adapted for storage of matter reaching from the small intestine and for absorption of basically fluid and solid. This is the main function of the large intestine. It is not the absorption of all the nutrients that has been taken place in the long tubes of jejunum and ileum. Now all the important substances have been absorbed now. In the large intestine, basically now the stool formation will start. Therefore, slowly there is absorption of water and formation of stool. Okay, that is what happens in the large intestine. In large intestine, there are few things which you need to remember are, one is appendices epiploicy. What are these? They are small bags of peritoneum filled with fat. You'll see small yellow tags on the wall of the colon. These are appendices epiploicy. Second thing is you will see some bands, three bands, those are three condensed longitudinal muscles on the outer wall of the large intestine. Those are known as tinea coli. Okay. So one is your appendix impulsive, one is your tinea coli, and other thing, and tinea coli, they are given three parts over here. Okay, let me mention one more structure, though it is mentioned later on. But the third important thing of difference in the small and large intestine is, the third thing is you will have presence of hostrations. What are hostrations? The large intestines appear like this. Because the tinea coli, the three longitudinal bands, when they contract, they'll give some bumps into the outer wall of the colon. So they are known as hostrations. The moment you see hostrations, you know that you're looking at a colon. Simple as that. Now the three bands of tinea coli, the names are given. It is not a very simple thing, or not a very simple thing, but not a very uh, frequently asked thing, but you should know that there are three bands of muscle: tinea coli, mesocolica, and omentellus. They are present at three different areas which are shown over here. Third thing I told you is presence of ostration. Now there is a table over here telling us the differences of small and large intestine. You should know this, that there's a length which is more in length, the small intestine is more in length. Okay. Caliber of large intestine is wide, surface area is less. Tinea coli, okay, circulation means hostrations, and appendices epiploidy, both all of these three are present in large intestine. Villi present in a small more, why? Because surface area. Plica circularis, again, to increase surface area, it gives the velvety appearance to mainly jejunum. Let me add over here, it is mainly present in Plica circularis, mainly present in jejunum. Then you have pious patches mainly in ileum. Okay. Distensibility, obviously, this is more distensible because now the stool is being formed. Fixity, greater part is freely mobile. Why? Because jejunum and ileum were freely mobile. Intraperitoneal, they give you the sound of peristaltic sounds which you hear on a stethoscope. While colon majority is fixed, though let me tell you over here, the transverse and the sigmoid colon were the one which are intraperitoneal, so they can move a bit. But understand, if the other parts of colon are fixed, there's not that much movement. Function, we discuss common site for some diseases are more common in small, some are more common in large intestine. Applied part, just have a look at it. If there is an infection in the small intestine, we call it as simply as gastroenteritis. Patient will come with the diarrhea, watery diarrhea, stomach pain, watery diarrhea. Okay, what is the treatment? If there's no fever, only diarrhea, look at the level of dehydration, at least start giving them ORS. Simple as that. No need for any antibiotics, though people give antibiotics still, but remember the mainstay of treatment is giving ORS. While what is dysentery? The moment the infection goes to large intestine, okay, it is going to go inside the wall of the large intestine. Along with diarrhea, there will be presence of blood and mucus in the stool. Then it is not simple diarrhea, it is known as the dysentery. Things are a bit more complicated now. Where we have more no, this more course of antibiotics over here. But some drugs are avoided in case of dysentery. So when there's a blood and mucus in the stool, this you have to ask in the history. Because patient will come of severe pain and very lethargic, very weak. They will always say, "Sir, I'm having diarrhea, I'm having loose stools, please help me," and all that. History is what you have to ask. Simple as that. So how long it is happening, what is happening, is there any presence of blood and all. Okay. So that is the basic difference. Now come to the next question of duodenum. Duodenum, mainly remember, we should deal with the relations. Now duodenum, to begin with, we all know a few things of the duodenum, that it is a part of the small intestine, right? It is a continuation of a stomach. Stomach continues into duodenum, It is mainly retroperitoneal, so major part of it is fixed. Gross anatomy wise, let me tell you, it is shaped like C over here, like a C over here, and then this slight elevation over here. This is duodenum. It is divided into four parts. First part is this transverse part. Second part is this vertical part. Third part again horizontal. Fourth is slightly ascending. So at one end over here, what you will have? You will have the you will have the stomach over here, and at one end you will have the beginning of jejunum over here. Both stomach and jejunum are intraperitoneal. Only this part duodenum is retro. So once you open up the abdomen, now, what you will see, you can see the stomach. Once you lift the liver, you can see the jejunum and ileum. Once you lift the greater omentum. But you won't be able to see the duodenum easily. For that, you have to pull out the stomach and look at its hand. You have to pull somehow the jejunum, look at its hand, then you will reach the duodenum. Because it is present more posterior. So it is divided into 4 parts, C-shaped structure. And do also remember that here you have an organ in its concavity. There is an organ over here, which is also retroperitoneal. That organ is pancreas. So remember these basic points. Being a part of midgut mainly, but do remember over here, theoretically and also important over here is that one is looking at the first, second, third, fourth part. Na? Up till the middle of the second part, up till over here, proximal to it, you have the foregut. And distal to the middle of the second part, here is the beginning of midgut. So it is not that the entire duodenum is midgut. The first part and the proximal half of second midgut. What is the part, which part are in the foregut of duodenum? Let me add over here that the foregut will have the first part and proximal half of second part. They will come in the foregut region. Distal to it, you will have the midgut region. This much information is fine. Why I'm telling you over here? Because this region will supply to which artery? Celiac trunk branches. This region by superior mesenteric artery. Right? Chalo, let's see now what is there in the note. So it is the shortest, widest, and most fixed part. Fixed why? Because retro extends from pylorus to DJ flexure. Shape is on level of C. Vertebrae is also remember. That is why it is so important. CT scans are so common nowadays. Okay, even in questions or in a practical life, it is so important that we should know this. Here the vertebrae are L1, L2, and L3. This will tell you that the first part is L1, second part is L2, and third part is L3. And fourth part is slightly going above, so it reaches till the L2. Fourth part of duodenum will reach till L2. Parts, it is around 25 centimeter long. Okay, so first, second, third, fourth part. You can remember it by 2, 3, 4, 1. 2, 3, 4, 1. What are these? These are 2, 3, 4, 1 is the length of all the 4 parts of duodenum in inches. So total comes out to be 10 inches. This is length of the duodenum in inches. So 2 inches 5 centimeter, 3 inches 7.5, 4 inches 10, and 1 inch is around 2.5 centimeter. 4 parts. Because total 10 inches is 25 centimeter. Okay, here's an image of the duodenum. First, second, third, fourth. Okay, fine. This is all basic idea that we should know. Okay. Now, the major structure over here will be found in the second part duodenum. This is the second part duodenum, right? So inside the second part duodenum, you will have some openings over here. You will have some openings over here. One slightly bigger opening and one slightly smaller opening. This bigger opening is obviously known as what? It is obviously known as the major duodenal papillae. Okay. And smaller opening known as minor duodenal papillae. What opens over here? It's very simple. Here you have the organ pancreas. And from above, what you have over here, understand, here you will have the stomach, right? And stomach, if I make some dots over here, say this color, okay, imagine this to be the stomach. Here you will have the liver over here. From the liver, what is coming down is the bile duct, CVD. So the CVD is common bile duct, and the pancreatic ducts, they are opening into the duodenal papillae. This understand. So major duodenal papillae is present where? Where is major duodenal papillae present? It is present 8 to 10 centimeter distal to the pylorus. And minor is present just a couple of centimeter before the major. So understand, this is image, this black circle, if I call it as a major duodenal papillae, where the major pancreatic duct and CVD basically open over here, common bile duct. And the main pancreatic duct, that is the duct of Versum. We'll study more in pancreas. They open into the major papillae. And just a couple of centimeter before it, you will have this as the minor duodenal papillae. What opens over here? The accessory pancreatic duct. What is that also known as? That is also known as duct of Santorini. Because you understand, the pancreas is mainly an exocrine gland. It is also endocrine, gives off the islet of Langerhans, but it is mainly exocrine. The pancreatic enzymes will help in digestion. Those enzymes are carried by the ducts, or juices are carried by the ducts having the enzymes, and those juices and the ducts, they open where? Into the duodenum. Similarly, the liver is going to form the bile for obviously the digestion and the emulsification of the fat that comes down through this common bile duct. These are the openings. So therefore, remember, it opens till the major papillae. No, so before it you have the foregut. After this you have the midgut. So remember, these two papillae, they are important. Colical longitudinalis, there is some longitudinal fold which is seen at the major duodenal papillae. So just remember its name. Now coming the most important part in duodenum, that is the relations of the duodenum. Let us see. Now there's a lot of table over here. Please give you relations. First part, second part, third part, fourth part. This relations also over here. Anterior, posterior, superior, inferior, all that. Okay. I won't start teaching you like that because else it's of no use. Just speaking after the theory over here. What I want to show you over here is understand the image. Anatomy is more about image. Understand. If you understood the image, things will be clear. Now see over here. We are looking over here relations of the first part of duodenum. Let me tell you, even on this 1 hour lecture, if you understood the relation of the duodenum, the small takeaway, that is going to be much beneficial for you. Because we have seen the past from 2020, 4 to 5 years, most of the PG exams, they started to ask the questions like this. Okay. So first part of duodenum, look at the anterior relations. Remember, duodenum is mainly retroperitoneum, so which are structures in front of duodenum. So first part, this is the first part of duodenum over here. Okay, I'm highlighting it with say green color, or let me highlight it say yellow color. So just you recognize it. This is the first part of duodenum over here. Okay. So see the relations in front of it. In front of it, you basically have the gallbladder and some part of the liver lying in front of the first part of duodenum. What is the use of it? Use is very important. Suppose the surgeon is removing the gallbladder and gallbladder is stuck to the duodenum. You can't just pull the gallbladder, no, else the bleeding will start from duodenum or gallbladder. Or you are doing a surgery on duodenum. So remember this structure. In front of the first part duodenum, you will have the liver and the gallbladder in front of it. Right? This is the anterior relation. Now look at the posterior relations. Duodenum itself being retroperitoneal, but there are other structures which are behind the duodenum. So this is again showing us the first part duodenum. What is behind it is basically all the portal triad structures. What are those portal triad structures? Basically going behind it is basically your common bile duct, which will be posterior to the first part duodenum. Then there was an artery which was a branch of hepatic artery going down. Which artery was that? That was gastroduodenal artery. So you have the gastroduodenal artery. Okay, and you will also have the portal vein over here. Basically portal triad structures, but not the hepatic artery. Okay, because in case of hepatic artery, we have what? We have the gastroduodenal artery. These three structures are very important, related posterior to the first part of duodenum. Now let me tell you over here, the question is normally, apart from stomach, duodenum is also commonplace for developing ulcers. And whenever there is a posterior wall ulcer of the duodenum which can perforate, there are good chances that this artery might also bleed, might also get perforated, and gives rise to severe hemorrhage behind the stomach and duodenum into the lesser and greater sac. Remember, this artery over here is present behind the first part of duodenum. Just imagine if you're lifting the first part duodenum, you should be aware. Just behind the duodenum, you have the artery, you have the duct, common bile duct, you have the portal vein. So there's so much of blood and there's so much of bile flowing just behind the first part duodenum. You should be aware of it. Okay, so remember this. First part duodenum relations. Now coming to the second part of duodenum relations. Here, what we look at is the second part of duodenum. Second part is that vertical part of the duodenum. What was the length of it? The length of it was 3 inches, around 7.5 centimeters. Okay. Again, in the second part, anterior, you will have, these are anterior relations. Again, in anteriorly over here, yeah, anterior relations over here, you again will have the same thing, gallbladder and the liver, because gallbladder and liver are not small structures. They cover a very big area. So gallbladder and liver will be over here. Then there will be transverse colon, because if you remember, then we have learned in peritoneum that the root of transverse mesocolon, it passed through the pancreas. So it was passing through the pancreas, also passed in front of the second part of duodenum. So there will be transverse mesocolon and transverse colon obviously attached to it. And when you say coils of small intestine, your mind is wondering that duodenum itself is small intestine. Yeah. But here the coils of small intestine is referring to jejunum or ileum. Because they are long tubes. They are 5-6 meters. 5-6 meters, understand. 6-foot guy is not even 2 meters long. The height of a 6-foot guy is not even 2 meters. Just imagine 5 to 6 meters of coiled tube inside your abdominal cavity. So therefore, they will obviously cover the front of the duodenum. So in anti-relations will be all of this. Okay. Therefore, remember any surgery in the duodenum or in these areas, you have to take care. Then coming to the posterior relations, what lies behind the second part duodenum, that is very, very important. Again, because behind the second part lies your right kidney. Along with it, you will have right renal vessels, some part of IVC. Again, nephrectomy, kidney operations, stones, cysts, cancers, so on. So when you are doing any operation, or there's any perinephric abscess, there's any nephritis, so many things are there. So if any surgical procedure is being done on the right kidney, remember in front of it lies the duodenum, second part duodenum. That is important. Okay, now coming to the third part duodenum. Third part was that lower horizontal part. This was our third part of duodenum. It was around 4 inches long or 10 centimeter long, right? Vertebral level, if you remember, L1, L2, L3. So this was lying around L3. This was lying where? Around L3 vertebral level. So again, remember in case of CT scan, if it is you're going from L1, L2, L3, you should know in L3, if you look at a luminal structure posteriorly, it is most probably the third part of duodenum. Looking at the anterior relations over here, so anteriorly over here passes your superior mesenteric vessels. Okay, so the superior mesenteric vessels are running in front of the third part of duodenum, and you will later on when you we look at the applied part, we also understand that the superior mesenteric artery over here. Okay, superior mesenteric artery over here, there can be a superior mesenteric artery syndrome when this artery might compress the third part of duodenum. So there can be a case when this artery, because of its more acute origin from the aorta, it might compress the third part of duodenum, leading to our partial or incomplete obstruction. That could also be a case. The superior mesenteric vessels are lying in front of the third part duodenum, and where will they go? Inside the mesentery. So the root of mesentery will also lie. Remember, we have learned in the root of mesentery crosses the third part of duodenum. In a previous lecture on peritoneum, we have learned that the root of mesentery crosses the third part of duodenum. Therefore, the third part duodenum anti-relation is root of mesentery, and obviously some further judgment. Coming to the posterior relation of the third part of duodenum, again, this is the third part behind. You will have more posterior structures. Basically, remember aorta IVC. Okay, along with that, you will have a few nerves over here and few lymphatics over here. Fine. Basically, aorta and IVC are lying behind. Why is that important? See, guys, aortic aneurysms are common. Okay, surgeries on aorta, IVC, they are done over here. You just have to keep in mind, right? So coming to the final, that the your relations of third and relation of the fourth part. Now, fourth part is a smaller part. Okay, this part over here, if I may highlight, right, this will be the fourth part of the duodenum, right? Fourth part of duodenum. So fourth part duodenum in front lies here. Here the transverse colon. Posteriorly, again, all those posterior abdominal wall structures. Posterior relations will be basically posterior abdominal wall structures. What is posterior abdominal wall? See, these are the structures onto which the kidney is sitting. So they are present most posteriorly. So you have psoas major muscle, you have the renal vessels, you will have other vessels and all that. So that lies posterior to the fourth part of duodenum. Anterior lies the transverse colon. Some of these things. Now, from the duodenum starts the jejunum. So therefore, the questions also come of this short question might come asking you about the suspensory muscle of the duodenum or the ligament of Treats. This might come as a 2-3 number question. Do remember. So see, duodenum is fixed, retro. Jejunum is mobile. So now there is a connection between a fixed pipe, if I may say so, and a movable structure, movable pipe. So at that junction, you have some suspensory muscle which is guarding that area. So it's a fibromuscular band as written over here, which suspends and supports the DJ flexure. Arises from left crus of diaphragm close to the right side of esophagus and passes behind the pancreas attached to. So it is coming basically from the diaphragm. There's this muscle band, you can say fibromuscular band over here. Some type of fibers are over here, upper part, middle part, and lower part. This is what we are referring to. This is the suspensory ligament of Treats over here. Again, applied part is important over here. Okay, this is your DJ junction. So this over here is your fourth part duodenum, that is part, second and first part, and this is jejunum. So this is all duodenum, that is jejunum. This is the DJ flexure over here. My suspensory muscle of treats over here. Blood supply duodenum, just there are superior, inferior pancreatic or duodenal arteries. Okay, so this is the blood supply, not of ligament of treat, but of the entire duodenum. Now let me add over here. Though we'll look more in the blood supply. As I told that duodenum is both coming is a part of foregut and midgut. Foregut had what? Celiactum. It will give what? It will give a hepatic artery. Just follow what I am trying to say over here. This will give what? Gastroduodenal artery. GDA, let us write. And this GDA will give off superior pancreatic or duodenal artery. Understood? This superior pancreatic artery is basically coming from celiac trunk ultimately. It is going to supply the proximal part of duodenum. While coming to the lower part of this inferior pancreatic duodenum, this is actually a branch directly from superior mesenteric artery, which is the artery of midgut, M for midgut. Okay, what the point? Venous drainage again finally goes to superior mesenteric vein, finally goes to portal. Lymphatics again, sort of same lymphs. Now supplies this, yeah, some applied aspect. You can add as much applied. Let me tell you, at least 3 to 4 applied is what you should know to write in exam or and to give answers in Viva. 3 to 4 of any structure is a must know. So you have duodenal cap, which is seen on the X-ray diagram. You have peptic ulcers. I told you posterior perforated ulcer, which artery can lead to bleeding over here, gastroduodenal artery. Diverticula can present over there. They can congenital stenosis and obstruction. Obstruction, I told you, even the superior mesenteric artery might compress which part of duodenum? Third part of duodenum, D3, leading to partial or incomplete obstruction. They can be cancers. Cancer can develop anywhere. Okay, I hope you got the point. So coming back again, just revising the whole stuff over here. You know, just duodenum started with a basic idea. Okay, 4 parts, length, where are they? What is the vertebral level? All these are important. Okay, then some important openings inside the duodenum. Then I didn't discuss any of these tables. We discussed them in the form of diagrams. This is you should must. If you understood this, then you can fill up the tables at your own wish. If you understood the diagrams, please do understood diagrams. And my request is to all of you, do practice diagrams. If you are looking for any shortcuts, I am sorry. There are no shortcuts. The only answer is hard work. Hard work is required. If you want to have a good, happy college life, you have to put some hard work to have a good college, good, happy college life. Else, it's going to be really very tough for you guys. Okay, so have some hard work for some time, and obviously it will give you benefits. To practice the diagrams or the relations, then you understand them. Then some amount of the treats over here, some blood supply, some applied aspect that is. Okay. Now coming to jejunum and ileum, we discussed their differences. Okay, no, we discussed difference of small and large intestine. Now let us see the differences in jejunum and ileum. Jejunum, I told you, is the upper part of the upper left part. If I may just write over here, jejunum line lies in the upper left part of the small intestine. Ileum lies in the lower right part of the small intestine, and then it continues into where? Ileum opens into cecum, the lower right side, where you have the appendix, right? So jejunum and ileum are suspended from posterior abdominal by mesentery that we all know. So these are mobile structures, mesentery. And the arteries which are lying inside this mesentery are superior mesenteric artery and their branches. Jejunum constitutes upper two-fifth part or upper left part. Upper two-fifth means around 40% is jejunum of the length, and so 60% of the length is ileum. More or less around this, right? So 2/5 and 3/5. On this diagram, you must know how basic. Okay. Now there are a lot of images also you see on social media and all those internet. No? They give you 2 images. Okay, spot the differences in these 2 images. All those things come and give you some time, 1 minute, 2 minutes. So if you look at these 2 images, identify the differences in these 2 images. One image is this, one image is this. Identify the differences. Okay, let me just slightly zoom this image and let us try to identify a few differences over here ourselves. Okay, in this image, you can see this wall is thicker. Difference number 1, this wall is not that thick. Okay. Other thing you can see that, okay, there's some difference in the architecture over here. Difference number 2, there's some difference in the architecture over here. Difference number 2. Then Then other difference we can point out is, okay, you can see the long arteries over here. These arteries are not that long over here. Difference number 3. Then we can see, okay, this yellow color is too much over here. Difference number 4, this yellow color is ending over here. Difference number 4 over here. Okay. These are the basic differences. So what we have seen is number 1 differences. This is the jejunum over here. That is ileum over here. J and I. Number 1 differences, the jejunum will have thick wall and will have more caliber also. Difference number 2 is that it will have less number of your arterial arcades. We call them as arcades. They are to develop anastomosis. Difference number 3 is that the jejunum will have longer vasa recti. They will have longer vasa recti. And fourth difference over here, that there's less fat in the mesentery of jejunum. Okay. Now let us see with the help of the table over here. So jejunum length, they are saying, okay, we know diameter. Okay, diameter also wider than jejunum. Thick wall and diameter wider. Walls are thicker. Appearance is more red, dark. It is more proximal, so more red. Though it's a subjective thing to say. Vessels will have less arcades. Arcades, no, the anastomosis. Okay. And fat is also small in amount. Here you will have more fat. Lymphoid will have few aggregations. Here you know this word pious, which is, these are the aggregations of the lymphoid tissue in ileum. Okay. These are the basic differences. Jejunum, ileum, you should know. Okay. Practical, let me tell you practicality. Suppose there is a whole gut on the table, right? And dissection, your DH, you have that viva, no, viscera viva, gut tube is lying down. And then part of gut is given to you, and you are asked to identify whether it is jejunum or ileum. One practical way, and not just in DH, but even OT operation theater, is once you pull up the jejunum, the small intestine. So small intestine is in your hands. What you are looking for is a mesentery. Okay. So you look through the mesentery. If you can easily look through the mesentery is very transparent. It is probably jejunum. It is jejunum. And if you pick up the gut and the mesentery is very opaque, it is thick yellow color, it is ileum. One basic difference is this. Because see, when we say na jejunum has thicker wall, ileum has thinner wall, then there is no single point of transition. The entire jejunum will have thick wall, the entire ileum will have thin wall. It's a constant, it's a continuous transition, gradual transition. Getting a point? So these differences only are most easily seen in the proximal part of jejunum and the distal part of ileum, the most farthest point of the two points of jejunum. But if you can see through the mesentery easily, what we call it as that therefore we say that in jejunum the windows are present. Windows meaning by they can easily see through. Windows are present. Ileum we say that the windows are absent. Okay, so this is practically very important point over here. Okay, fair enough. Let us move from here. So this jejunum ileum, again differences. Less arcades, long vasa recti, more plica circularis. Plica circularis are folds. And due to this, see, it gives a velvety appearance. And let me tell you, a recent exam question came of the barium meal follow through. If you look at a barium meal is when you give a radiopaque dye to drink and then you take X-rays. Volvule conniventus, all these small lines, these sort of lines is more like feathers you will see in case of jejunum. That was the question that was asked. Because there's so much velvety folds that the dye will stick to it, and as it is opaque, radio opaque, it will come in the X-ray. This velvety appearance known as conniventus volvule conniventus. That is a feature of jejunum. And no fat in mesentery, it has more fat in mesentery. Difference jejunum ileum to remember. Okay. Then you have the Mengel's diverticulum. Let us see that topic also. I hope the difference is clear. So coming to the Mengel's diverticulum, we have Mengel's diverticulum is basically anatomically, embryologically more important. It is the proximal part of the VID, vitreointestinal duct. Okay. Normally disappears during the 6th week, but in some people it might persist and then it might give rise to a few problems. There's a rule of 2 which is frequently used. What is this rule of 2? For case of Mengel's diverticulum, first, I hope you got the point. What is vitreointestinal duct? Vitreous is that, this yolk sac part of the embryology. Intestine is developing intestine of the embryo. You should know that in embryonic life, for 3-4 weeks in between, the midgut comes out into the yolk sac, and then it goes back into the abdominal cavity of the embryo. So in moving back, there's a connection that is the VID, vitreointestinal duct. That obviously removes it, disappears. In some people, some part of it might left. That gives rise to a diverticulum. Diverticulum is like you have seen those balloons. One are those regular balloons, and one are those balloons which have few appendages coming out like this. So this is a sort of diverticulum over here. Okay, so that is known as Meckel's diverticulum. Now, the rule of two is it is present. It is not a very important. 2% of population. That is a big number. More in males, it is present around 2 feet from the ileocecal wall. That is, ileocecal wall is the terminal point of ileum. It is present around proximal to 2 feet. 2 feet is around how much? It is simple to hit around 30. 1 foot is around, say, how much? 30 centimeters or 50, 60 centimeter maybe. The length of diverticulum is around 2 inches, roughly around. And 2% of the people who have this develop complications. Complication can be there. Sometimes two types of heterotopic mucosa are also seen. And inside this diverticulum, there can be gastric tissues or pancreatic tissue. So if there is a gastric ulcer, this diverticulum might also develop some gastric ulceration. Remember that. Okay. So this is the position they are showing of the Meckel's diverticulum. Just look over here. This is the position over here. So this is your ileocecal junction over here. And you can say around 2 feet approximately, you have this Meckel's diverticulum positioned over here. Okay, also in this diagram. Clinical anatomy, let us see over here. Bleeding and diverticulitis. Inflammation is diverticulitis. Okay. So bleeding, common in young children, may lead to hematochezia and anemia. So sometimes there's so much of small bleeding that patient present as weakness. Then you take a CBC complete blood count and you see hemoglobin of 7 or 8, something like that, or even 9. Then you look out for the causes. Diverticulitis, then it might mimic appendicitis because it is close to appendix. So that can be a DD of it, can lead to this peritonitis or intestinal obstruction, right? So go through the Meckel's diverticulum. Meckel's diverticulum is more of a surgical topic, but remember its anatomy is basically more dealt with case of embryology, it's related to the embryology topic. But yeah, that was all in today's session, guys. I hope you enjoyed. So some things that we did was basically your stomach, duodenum, jejunum, and ileum. Okay, basic differences. Stomach in detail, duodenum relations, I told you, very important. And look at basic differences in jejunum, ileum, plus a couple of ligament of treats and the topic of this Meckel's diverticulum. Okay. So that's all from my side for today. Thank you for listening and see you soon. Till then, all the best. And do your hard work, and if there's any issue, any problem, do write us. That's all. Bye-bye. Take care.